Dr. Hasanain Kahtan. Today, the title of my lecture is Daily Activities and Nutrition in the Elderly Patient. Disability in old age, the relationship with oral health. One wish is common for all older adults from the viewpoint of living a good life, which is to have a good functional ability in everyday life, so that one can manage for as long as possible without help. Three terms are commonly used to identify vulnerable older adults: frailty, comorbidity, and disability. Frailty is a physiological state of increased vulnerability to stressors that results from decreased physiological reserves. Comorbidity is defined as the concurrent presence of two or more medically diagnosed diseases in different organ systems in the same individual. Disability is defined as difficulty or dependency in carrying out activities essential to independent living, including essential roles, tasks needed for living independently in a home, and desired activities important to one's quality of life. Introduced a theoretical model for the consequences of disease and aging to be used in epidemiological, gerontological, and clinical research. The model is a further development of WHO's International Classification of Impairments, Disabilities, and Handicaps, and describes how chronic and acute conditions affect functioning in specific body systems, basic physical and mental actions and activities of daily life. And the second is the personal and environmental factors that speed or slow disablement. In recent years, this conceptual model has been increasingly used in American and European gerontological research. This figure represents the simple scheme for the disablement process, which starts for the main path to the disability, which start from the pathology to impairments to functional limitations and disability. And you can notice the several factors that may affect on this pathway, which are risk factors, extra-individual factors, and intra-individual factors. According to the model, pathology refers to biochemical and physiological abnormalities that are detected and medically labeled as disease, injury, or congenital developmental conditions. For example, osteoarthrosis and diabetes mellitus. Detection of pathology often relies on the evaluation of more manifest signs and symptoms. Pathology may be caused by a disease or by physiological and biological age-related declines in the individual. Impairments are dysfunctions and significant structural abnormalities in specific body systems. Medical procedures to evaluate impairments include clinical examination, laboratory tests, and patient's medical history and symptom reports. Impairments reflect the consequences and degree of pathology. For example, decrease of articular cartilage caused by osteoarthrosis of the hip. Are restrictions in performing basic physical and mental actions used in daily life by one's age gender group. These are generic actions which direct the general abilities of body and mind to do purposeful work. Fundamental physical actions include overall mobility and individually separate and distinct motions and strengths. then we can define the disability as is the experiencing difficulty doing activities in any domain of life. The domain is typical for one's age, gender group, of course, due to health or physical problems. According to the Verbrugge and Jette, the words action and activity are simple devices to distinguish the concepts of functional limitations and disability. Disability has a social factor that influences on the pattern of behavior arising from the loss or reduction of ability to perform expected or specified social activities. Disability, thus, refers to the expression of a functional limitation in a social context. Causes problems with the dexterity of the shoulder, which represent here a functional limitation, which again makes it difficult to pick apples. Here is the disability. Also, another example is osteoarthritis in the hip will cause problems with general mobility of the hip joint, which may result in difficulty sitting at the floor and playing with the grandchildren. A decline in general mobility may also make it difficult. For example, to go to art exhibitions with many stairs or to take part in tours arranged by an organization. Several factors contribute to shaping the dimensions and severity of disability. The individual's perception of the situation, the perception of the situation by others, and their reactions and expectations may also play a role. The characteristics of the environment and the degree to which it is free from or impede with physical and socio-cultural barriers. The disablement process explicitly includes factors that affect the pace and direction of disablement. These factors can be external, like the physical environment or the social relationships, and internal, like the health behavior. First, disability is a predictor of important outcomes such as hospitalization, institutionalization, and death. It also has a powerful effect on happiness and life satisfaction. Second, a given disablement process can lead to a vicious circle and sometimes even cause new pathologies and associated consequences. Within a disablement process, these feedback loops are often seen in frail people. For example, a woman with painful arthritis may no longer be able to walk with her dog disability. This eventually reduces her aerobic capacity and muscle strength impairments, further reducing mobility and social activities function, which represent the functional limitations and disability. Causing one functional limitation, causing one kind of disability. While multiple co-occurring diseases and impairments are common and each has a synergistic effect that is difficult to investigate, thus it might be appropriate to expand the model of the disablement process as shown in this figure. Risk factors for disability. Number one, a number of chronic diseases are observed more frequently in disabled older adults than in those who are non-disabled. However, Not all diseases cause disability, and some diseases cause more disability than others. Diseases with large effects on functional ability include stroke and other neurological diseases, heart diseases, cancer, respiratory diseases, high body mass index, diabetes, depression, dementia, and musculoskeletal diseases. Second, it has also been reported that the presence of more than one chronic disease in an individual or comorbidity is related to the presence of disability and to that person's future risk of disability. For example, the number of chronic disease in a disability-free group age 65 and older at baseline is directly associated with risk of losing mobility over 4 years. 3. In addition, several types of impairments have been shown to be related to disability. For example, hearing impairment, visual impairment, poor balance, weak muscle strength, loss of muscle mass, motor impairment, pulmonary impairment, and cognitive problems. Number 4, it's also well established that social and behavioral risk factors play a large role in the disablement process. This has been shown for socioeconomic position, social relationships, smoking, nutrition, and alcohol. Promoting health and to the latest years of life, into the latest years of life. Exercise is relevant to primary, secondary, and tertiary prevention. Older adults at all levels of health and function can improve or maintain their exercise tolerance and strength through targeted exercise programs. Lack of exercise is strongly associated with disability onset, while conversely, regular exercise appears protective in maintaining function. The main pathway to oral disability. The disability process can also be looked at from an oral health point of view. Locker has proposed a model with a general pathway from disease via oral impairments, such as edentism, and oral functional limitations, such as difficulty in chewing, through to disability, such as inability to consume a range of foods, and impacts on social rules, for example, avoiding going out with others, thus contributing to the higher prevalence of current decay. The tooth brushing and flossing become difficult to perform adequately with a decreased manual dexterity. In addition, loss of functional abilities may reduce self-esteem, and individuals may lower the priority given to the oral hygiene and regular dental care. Some older adults may feel that tooth loss is an inevitable part of growing old. It seems quite feasible that mobility disability may limit an older person's access to dental care. Lack of proper dental care for caries and or periodontal disease might eventually lead to loss of natural teeth, with replacement by complete or partial dentures. Among institutionalized older adults, poor mobility reduces a resident's ability to access dental care outside the nursing home, and accessing care within the institutional setting is difficult because most dentists are not interested in providing services and or feel inadequately trained. Disability are at larger risk of having oral health problems. This has several implications. First, it should be recognized that prevention of disability in older adults will eventually also cause better oral health in the old people. For example, promotion of physical exercise and to stop smoking. Here the effect may be indirect via functional ability, which means a treatment of a disease or increased physical exercise may improve the functional ability of older adults, thus making it easier to take proper care of the teeth. But the effect may also be direct, which means treatment of a specific disease such as diabetes or stopping smoking may have a direct beneficial effect on oral health. At larger risk of disability and of oral health problems, this should be recognized in the multi-dimensional interventions which take place in several communities. For example, in Denmark, where all 70 plus old age years old living at home are offered annual preventive home visits. Here, the preventive home visitors should be aware of oral health problems as one possible consequence of feeling of fatigue. Third, problems with fine motor activities caused by dexterity problems may make it difficult to take care of the teeth and periodontium. This may be relieved by an enlarged hand grip or an electric toothbrush. But if the person is severely disabled, she may need daily help with toothbrushing and interproximal flossing. For institutionalized older adults, one way may be to assist nursing staff through educational initiatives which should encourage them to offer daily mouth care as an integral component of their personal hygiene care for all disabled older people in residential and home care. This care includes daily tooth brushing, quarterly or semi-annual preventive assessments and service education for daily caregivers, nurses and aides, so that they learn the essential skills to provide daily mouth care for frail older adults. Fourth, older people with personal care disability, for example, may require more frequent dental visits to compensate for their physical disability. Frail and functionally dependent older people living in long-term care facilities or at home have special difficulties in accessing dental care because the problems of attending a dental clinic often appear too great to be overcome. Nutrition, here the second big subject in our lecture, in nutrition and oral health for the older person. Nutrition and health are intimately linked together. Inadequate nutrient intake or absorption will result in overt or subclinical deficiency states, which may have a significant effect on health outcomes for older people. There is significant evidence of malnourishment amongst older individuals, particularly those who are admitted to hospital with a reported prevalence of between 20 and 70% in a range of clinical studies. Nutrition and oral health. Oral mucosa. The effect of that change on the relationship between oral mucosa, mucosal integrity, and nutritional deficiencies is unclear. Oral mucosa has a very rapid rate of turnover, like most of the mucosal lining of the gastrointestinal tract. As a consequence, micronutrient deficiencies that affect mucosal turnover and integrity will result in oral mucosal lesions at an early stage. Iron, vitamin B12, and folate. These micronutrients are critical for mucosal integrity. Deficiency states will result in alterations to the mucosa of both the tongue and the oral vestibule. The papilla of the tongue tend to flatten and the mucosal covering reduces in thickness and in keratinization, resulting in a smooth surface that is red in appearance rather than the dusky pink of normal lingual mucosa. While for the vestibular vestibular ulceration is more common with deficiency states, particularly minor epthi, as are red lesions, erythroplasias of the oral mucosa, and any erythroplasia needs to be investigated with care and urgency as they are regarded as pre-malignant lesions. Stomatitis associated with the area beneath the plate of a denture base. Candidal infections are commonly associated with both denture-induced stomatitis and angular cheilitis. In addition, the angle lesions can be infected with Staphylococci. Most of these conditions respond to simple micronutrient supplements. However, where bacteria or fungi are also involved, then appropriate antimicrobial therapy is also essential. Alcohol. The relationship between oral health and alcohol consumption is complex due to the many and varied components in alcoholic beverages. Oral cancer. There is an increase in both oral pre-malignant lesions and malignant lesions in individuals who consume alcohol. Smoking. Smoking and alcohol consumption have a synergistic effect in terms of the development of oral pre-malignant lesions, with higher relative risk of individuals who both smoke and drink developing lesions compared with the cumulative effect of the drinking or smoking. The relative risk for individuals who both smoke and drink alcohol is approximately threefold that of people who only drink alcohol. Chewing tobacco is also associated with increased risk of oral cancer. Bacteria on the surface of teeth and within demineralized enamel and dentin and fermentable carbohydrates in food. The bacterial biofilm begins to form on the surface of the tooth immediately after it has been cleaned, but the biofilm does not reach acidogenic maturity until it is about 4 days old. There is consistent evidence linking caries to sugars intake in younger people, including national epidemiological studies. There are fewer data linking decay in older adults to sugar consumption. Those data that are available suggest that root caries is linked to high sugars intakes and to the use of sugar as a sweetener in tea or coffee, particularly in men. One particular area of concern is the high level of untreated dental caries in institutionalized older adults. This is the result of a relatively high frequency of sugars intake daily to try to maintain energy consumption at adequate levels in frail older people and poor access to dental care and preventive services. for preventing caries in older populations. The rule of thumb for young people is four sugars containing intakes per day. But the increased risks seen in older people, particularly those with the dry mouth, may make even this level unacceptable. Sugars in medicines. Sugars are used in prescribed products in two circumstances, either as energy supplement for the ill or as a preservative and sweetener in conventional drugs. High energy food supplements in liquid or syrup form are used to maintain an adequate calorific intake in debilitated patients. They contain large quantities of sugars and are sipped off long periods of time. Furthermore, the syrupy nature of those preparations reduces the rate of oral clearance, particularly in individuals with impaired salivary flow. Sugars that are used as preservatives in syrups and mixtures and to hide the bitter flavor of drugs are also a problem for older people, where the use of liquid medicines and those that are sucked again becomes common. Cariogenic. This combination occurs in starchy snack foods commonly used as between meals adjuncts to diet. Refined sugars. Refined sugars are used extensively as both sweetening agent and preservatives in foods, often being described as hidden sugars. In this later role, as savory food can often contain significant quantities of added sugars. Example would be tomato ketchup, tinned vegetables, and baked beans. Alcohol. Alcoholic drinks also contain sugars which can initiate decay and acids which also dissolve tooth tissue. This increased acid burden in the mouth associated with generalized neglect in individuals who become addicted to alcohol can result in very extensive carious lesions on multiple teeth. Smoking. Smokers have a higher incidence of caries than past smokers or non-smokers. The mechanism for this phenomenon is unclear. A salivary link is unlikely as they show greater levels of output than non-smokers. However, smokers are more likely to consume sugar-containing drinks and snacks than non-smokers. Furthermore, their oral hygiene tends to be poorer. These effects influence both coronal and root surfaces of teeth. Serve a primary function in food's consumption, breaking down large pieces of food into smaller particles and mixing them with saliva to allow a bolus of food to be formed for swallowing. This comminution of food along with salivary enzyme activity is an important component of the initiation of digestion of food. The process of breaking up food and converting it into a bolus to be swallowed is associated with the release of tastings from the food, enhancing our enjoyment of the things we eat. Impaired chewing function will affect all of these components. People with poorer masticatory function are less efficient at breaking food down to facilitate bolus formation. They tend to use fewer chewing strokes and accept larger food particle sizes in the food bolus prior to swallowing. Whilst there are no documented problems associated with this, there could be an increased risk of choking. in people who chew their food less effectively and who also have impaired swallowing. For example, people with dysphagia post-stroke. Radiation damage, or as a side effect of drugs, will experience increasing challenges in terms of chewing and swallowing, as the lubricant effect of saliva will be less and of forming food particles into a bolus for swallowing, as saliva is the glue which holds the bolus together. The number and distribution of remaining natural tooth and or the presence of complete or partial dentures are likely to influence the ease of chewing. Another notice, there is a particular problem when trying to chew with conventionally retained dentures where the prostheses are controlled by the oral musculature and the forces of adhesion and cohesion between the salivary film between the denture base and the oral mucosa. Food particles will act as a profound destabilizing influence during chewing as forces are applied eccentrically to the dentures, so stabilizing pressure is required from the tongue musculature. For example, during periods of illness. Furthermore, it is a skill that is likely to be more difficult to learn with increasing age. People who are edentulous in the lower jaw and function with denture against some natural teeth in the upper jaw report more problems with chewing and swallowing foods than any other combination. Masticatory efficiency. Variables which influence the ability to break down foods by chewing are usually assessed by measuring the size of test foods that have been chewed for a specific number of chewing cycles, or, which is the second method, or have been chewed until the study participants would feel the particles were small enough to swallow. The test food is then removed from the mouth and the particle size analyzed using a graded sieving method or image analysis techniques. Dentures compared with natural teeth and with complete dentures compared with a natural dentition. The effect of age alone on chewing efficiency is negligible, although there is some reduction in oral motor function in older people, probably relating to the altered muscle bulk. Understandably, chewing efficiency is affected by the number and distribution of teeth. Maximum biting force is reduced in people with advanced periodontal disease and increasing tooth mobility. The relationship between masticatory efficiency and biting force is unclear. This is particularly difficult to clarify in subjects who have periodontal disease with mobile teeth, as they also tend to have fewer teeth. The relative impact of the effect of mobility of teeth compared with numbers of teeth has not been clarified, which includes reductions in gastric motility and atrophy of the villi. On the walls of the small bowel, these changes are likely to influence the ability of an older person to digest and absorb foods. Masticatory efficiency and food choice. There is significant evidence that food choice is affected by chewing ability. As masticatory efficiency is progressively impaired through tooth loss, individuals report progressively progressive increase in their perceived difficulty chewing foods. If a person finds a specific food difficult to chew, then as a rule they choose to avoid that food rather than persevering with the challenge. There are specific groups of foods that are more difficult to chew, which include raw carrot, nuts, fibrous vegetables, and some fruits, which are affected by this phenomenon. Stick to the surface of the acrylic of the denture, making the individual uncomfortable. In this circumstance, the leaf has to be removed mechanically from the plastic, either by taking the denture out of the mouth or by pushing against the leaf with a finger. Obviously, this is not socially acceptable, so again an avoidance strategy is taken. People become handicapped by their oral status. Consequently, they suffer impaired intakes of certain fruits and vegetables and the associated key nutrients. One specific area of concern is the markedly reduced area intake of non-starch polysaccharides, dietary fiber, when compared with national dietary reference values. It is common for intake to be less than 50% of that which would be regarded as necessary for good health. There is also some evidence of dietary change towards a less healthy diet with increased intakes of saturated fats and cholesterol, and an increasing proportion of foods energy derived from the fats in older people with reducing number of teeth. Method they use for food preparation. This occurs both during the transition to edentulousness, but also recent evidence from the US health professional study has shown similar trends among people who had 5 or more teeth extracted over an 8 years period. Therefore, there is an increased risk of foods being over-prepared, for example, removal of the skin from fruits and vegetables, or overcooked to allow them to be chewed by a person with reduced chewing efficiency. A broad range of nutrients can be affected by these phenomena. Some of the change may be beneficial. For example, carotene is more bioavailable from cooked compared with raw carrot, but others will be lost either as a consequence of denaturation of proteins during cooking or as they are contained within specific zones of a food. For example, the vitamin C in potato is located very close to the skin. If this is removed, the vitamin C goes with it, and potentially combating the effects of aging. Obviously, any reduction in dietary fiber may impact more broadly in terms of cardiovascular disease and cancer prevention. Prevention of dietary change. There have been a number of studies that have looked at oral health interventions in terms of chewing function and dietary change, almost without exception, and an oral health intervention designed to improve chewing efficiency. Whether it involves making removable dentures, bridge work, or implant-supported prostheses, showed similar outcomes, that the participants felt able to chew better, but they did not then go on to make any change to their diet. Change in dietary habit or any social habit is a complex process, as part of which the individual has to be aware of the need for and rationale associated with any specific change. 1.4% of the population had disorders of smell and 0.6% had disorders of taste, with a strong age-related trends such as such that 40% of those with chemosensory problems were 65 or older. General health status, other sensory impairments, functional problems, and a variety of other health related characteristics were also associated with chemosensory difficulties. Taste perception with age. Taste is perceived through the taste buds on the dorsum of the tongue, the soft palate, the pharynx, larynx, epiglottis, and in the upper third of the esophagus. The quantity and distribution of taste cells do not appear to change in normal, healthy adults with increasing age. Tastants must be dissolved in fluid derived from saliva to allow the specific taste to be perceived. Individuals cannot taste their own saliva as a product of habituation, but there are changes in the ionic composition of saliva and in the salivary mucins with age that must result in a progressive change in this background flavor. Comprise both alteration in the ability to discriminate tastes, that they are present at all when compared with water, and in recognizing the 5 different taste qualities in food compared with the young. There are 5 principal tastes: bitter, salty, sour, sweet, and umami. Umami is the taste of savory, which is perceived separately from salt and sour. Bitter, salt, sour, and to an extent sweet are reduced by aging in healthy unmedicated adults. It has also been shown that these effects are amplified in people who take multiple medications and in those who are chronically ill. It is interesting to speculate that this amplification may also be associated with changes in saliva and other oral secretions in individuals who are taking multiple drugs. The effect extends to all the principles tests, with an increase in the detection threshold of 11.6 fold for sodium salts, 7 folds for bitter, 5 folds for umami, 4.3 fold for acid, and 2.7 fold for sweet. With the denture base, the rationale for this is less clear, as there are few, if any, taste buds on the hard palate. Impaired taste is more likely to be associated with the proper release of tastants from food which are not chewed. An obvious solution to altered taste is to explore the value of flavor enhancers on food consumption. Flavor enhancement can take the form either of adding artificial flavors to fortify the food, or adding sometimes that amplifies natural taste. The most common chemical in this later group is monosodium glutamate. Some beneficial effects, either as an arrest and decline of food intake or of overt increases in energy intake and even increases in body weight, have been seen with this approach. Perception of smell with age. Reductions in smell are generally more profound and more consistent than changes in taste. Nearly 2/3 of all adults over the age of 80 showed some level of disturbed sense of smell. Rates of change are higher in men, current smokers, and those with stroke and epilepsy. Olfactory thresholds are elevated for all others by between 2 and 15-fold when younger populations are compared with the old. Central nervous system pathology will also impact on olfactory perception, including facial trauma and both Alzheimer's and Parkinson's disease. Indeed, reduced olfactory ability has been suggested as a marker for cognitive decline. and upper respiratory tract infection, and all food tastes bland. Reductions in chemosensory ability can result in altered food choice and reduced energy intake, and there have been suggestions that individuals may also be at increased risk of food poisoning as they would not be able to detect rotten foods by their smell. Texture. Food texture plays an important and little recognized part in the ability to process the food in the mouth. This ability changes with the increasing age, associated both with altered oral status and reduced muscle bulk, limiting chewing strength. There are some attempts to compensate for this by older people by increasing the number of chewing strokes used to process a mouthful of food. Despite this, older subjects swallow the food bolus with larger particle size of food than in younger cohorts. Harder to chew and swallow foods that are avoided are those that require high forces or prolonged chewing to reduce them to a state suitable for swallowing, as well as those that adhere to dentures and or teeth. One final variable that also influences perceived texture in the oral environment is salivary function. Individuals with poorer salivary flow have more difficulty chewing and swallowing foods in general, as the lubricating and binding actions of the saliva are reduced. This will have its greatest effect with foods that are perceived more difficult to chew. Thank you.